Okay, hi everyone. So welcome to Grand Rounds today. Again, reminder, if you're in the building and able to come down, then feel free to come to W13068. Those are the two right room numbers. And we do have coffee, a few muffins and juice in the back. And so today I want to welcome our Grand Round presenters, a group of 3 PGY3 residents. But first, I'll acknowledge that we are on the unceded territory of the Algonquin Anishinaabe people, and CHEO honors them and all First Nations, Inuit, and Métis people. Today, we have, again, 3 presenters, Dr. Nayef, Alotaibi, Dr. Yousra-Imane Benaskeur, and Dr. Liyana Kukkadi. And they are going to talk today about a provoking title, so Invisible Barrier, Addressing Racism in Medical Education. Now I'm going to hand it off with that.
Hi, thank you for this introduction. So first off, we just want to thank Dr. Irabana Simpson from Pediatric Hematology Oncology, who was our supervisor and provided some help and support in preparing this presentation. Next off, oh, my slides. Yeah. Okay. We have no conflicts of interest to declare, and here are the learning objectives we're hoping to cover today. So first, explaining how racism has influenced the current state of medical education from a historical standpoint, then recognizing the impacts of racism and discrimination on learner experience in our clinical environments, then identifying opportunities to advance equity and mitigate discriminatory behaviors in medical education, and finally, we'll be looking at some tools and frameworks we can use to address microaggressions as a bystander. Before going any further, we do want to say that racism is a very broad and complex topic, and that for the purpose of this presentation, we'll be focusing on some examples to illustrate what racism can look like in the healthcare system. They're not meant to be an exhaustive list by any means. It will not be representing every single form of discrimination someone can face in the healthcare system, and it will not represent every single minority or community who can face racism in the healthcare system. Again, there are examples for us to reflect and discuss and learn from them, but will not be representative of every experience, lived experience. That being said, given we'll be using some specific examples, they may be triggering for some, they may remind you of some lived experiences, and we want you to be aware that you may have some strong emotions associated with those, but we do think it's important for us to have this space for honest discussion and say things as they are and hopefully learn and improve from that. Now I will pass on to Nayef, who will be going over some historical aspects of racism in medical education.
Thank you, Iman. Thanks everyone for joining today. So I would start off by saying that we are all in the process and the journey of learning. We do have so many concepts and terms that we're going to discuss today. The lists include racism, race, discrimination, prejudice, microaggression. And let's start by defining some of these terms, and let's start from the beginning. I just would like to remind everyone that race is a pure human invention. It doesn't have any biologic or scientific basis. And I would also start by describing or talking about social identity. So social identity is the perceived membership within certain social groups based on specific physical, social, and or mental characteristics. And there are a few characteristics about social identity. These are things that we might choose or we are born into. They might be visible or invisible. They might be static or fluid. In addition to that is that the hierarchy of our identity is socially constructed. The ranking of groups and the importance of specific differences are determined externally by our society. And each of us has multiple social identities that will connect and interact in different ways. And finally, the importance or prominence of any given identity may change depending on the situation that we are in and who we are dealing with at any given time. So this is a great article from a young Canadian writer from British Columbia. She says that sometimes she feels like an undercover Black woman. She is biracially, but she is generally perceived as white because of her light skin tone. Race is something that is applied to people. So she describes that when people say racist things to her, they are assuming that she's not a person of color. And just using few more examples. So race is an example of social identity. And the first picture I have here, we do have Lucy and Maria Alimer from Gloucester, from the UK. They said that when they walk down the streets that they are mistaken that they're friends. But amazingly, they are twins, even though Lucy is white and Maria is black. And here I do have another example of Marcia and Millie Biggs. They're also twins. And the last example is James and Daniel, who are also twins. So it's just so fascinating that this is even possible where in each of these cases, one twin has a skin tone that would be considered as a black, while the other looks white. So I gave these examples to illustrate that racial identity and other social identities can be fluid and change over time. And although an individual may self-identify with a specific race, this can be different from the race that they would indicate on a survey. This might be different than how they are classified or observed from others. And this could be different from their racial phenotype or from their ancestry. In a survey that was conducted in 2015 of a multiracial US adults, they found that people have perceived themselves as to belong to more than one racial social identity. And moving on to chat about bias. So bias is a tendency, inclination, or prejudice toward or against something or someone. Some biases are positive, and helpful, but some are negative too. These are influenced by stereotypes rather than actual knowledge or of an individual or circumstances. Now I would like to chat a little bit about the levels of biases. So we do have biases at an individual and a systematic level. In general, bias will operate at an individual and a systemic levels of society. From an individual perspective, one's beliefs or a person's beliefs or actions that serves to perpetuate oppression, whether they are conscious or unconscious, externalized or internalized, interpersonal, where the interactions between people both within and across differences, and the institutional biases. The structural biases is the broadest and arguably the most challenging bias to tackle. And it's the summation of the effects of bias and discrimination across institution and across history. And moving on to chat about the definition of racism and on an individual and a systematic level. So racism from an individual perspective is the belief that a race is a fundamental determinant of human traits and capacities, and that racial differences produce an inherent superiority of a particular race. And from a systemic perspective, it's the systemic oppression of a racial group to the social, economic, and political advantage of another race. And now I move on to do a quick review of the history of racism in medicine. It's not a very extensive list, but it's just give you an idea of what has happened in the past. So starting from the 17th century, the first picture indicates slavery that was established in the USA. But the second picture on the lower part of the slide, a Swedish physician, his name is Dr. Carl Linnaeus. He did link geographic origin, skin color, and character together. So he said, Europeans are usually fair, gentle, accurate, inventive, governed by laws. Africans are usually black, crafty, indolent, and governed by caprice. Americans, copper-colored, obstinate, content, and regulated by custom. And it's the idea that somehow skin color has a social meaning. Moving on to the 18th century, another physician in 1839, his name is Dr. Samuel George Morton from the USA, measured skull to prove racial hierarchy in the USA. So he felt that measuring a skull size is a proxy of intelligence. Larger skulls give Caucasians decided and unquestioned superiority over all nations of Earth. And the other part, the other image of the slides indicates the Indian Act that was established in Canada in 1876, which has a lot of implications to access to healthcare for Indigenous people. And in 19th century, in 1932, the US Public Health Services started and began the Tuskegee syphilis trial, where they left 404 African-American men were untreated with latent TB despite the discovery of penicillin. They were discouraged to seek medical treatment because they wanted to monitor their symptoms, and how the disease progresses. And the other part of the slides, I'm discussing a hypothesis that was established in 1996. It's called the slavery hypothesis, or the African gene theory. It used to explain how high rates of hypertension among African Americans were a genetic difference, so that their slave could survive in the traverse across the ocean. And moving on to the 20th century, in 2005, the FDA has approved the first medication for Black people, which is a Bidil. This is a heart medication that makes the erroneous connection, again, that there is a genetics of race, and it does signify that race has a distinct geography, ancestry, and genetics. And of course, in 2020, we all have witnessed the COVID-19s and the long-standing effect of history of systemic racism, and it was documented the higher rate in Black and Indigenous people. And this slide is taken from the Ottawa neighborhood study that did discuss the racial disparities in COVID-19 rates. So the slide, the study showed how Black and Middle Eastern residents of Ottawa were affected by COVID-19 during the early part of the pandemic. The quantiles from Q1 to Q5 represent the neighborhoods that have been least to most severely affected by COVID-19 infection in Ottawa. The bar shows the proportion of Black and Middle Eastern Ottawa residents that resides in these areas as compared to their proportion in Ottawa. And it's clearly that Black and Middle Eastern population have been affected the most during this pandemic. And moving on to talk about the social determinants of health, and to better understand the effect of race and racism on health outcomes. We feel that, and we believe that racism does affect the accessibility and quality of education, economic stability, social and community context, accessibility and quality of healthcare, and housing and environment. And I'm having an example of each single one of the social determinants of health here. So African Canadian children are more likely to be streamed into basic level academic programs instead of advanced level programs. Black Canadians earn 75.6 cents for every dollar that a white Canadian earns. Middle Eastern and Black Canadians are disproportionately and negatively profiled by the police. African Canadians experience disproportionate levels of chronic health conditions, and the poverty rate among Black Canadians is more than 3 times the average of a white Canadian. So this draws the conclusion to the fact that racism is a force that drives the social determinants of health and acts as a barrier to health equity. And moving on to chat about the Canadian context. So in Canada, as per the Canadian Public Health Association statement in 2018, the two most blatant forms of racism are racism against Black people and our treatment of Indigenous people. In the Canadian hospitals and other healthcare systems, Black and Indigenous people often face systemic discrimination and inferior treatment. This brings me to one of the sensitive slides of this topic. It talks about a recent and a terrible examples of the reality of racism in medicine is the death of Joyce Ishkawan in a hospital in Joliet in Quebec in 2020. So she presented to the hospital with abdominal pain, and a medical staff treated her with morphine while ignoring her assertion of a history of an adverse morphine reaction. She died, and the circumstances leading to her death are being investigated. Prior to her death, she recorded racial slurs that were expressed about her by hospital staff. And on the left, Brian Sinclair, who was 45-year-old, when a staff in the community center referred him to a Winnipeg Health Sciences Center to have a catheter change on September 19, 2009. 34 hours later, he was found dead and on the waiting area at the hospital, because everyone just assumed that he's intoxicated or he's trying to find a shelter. And another glaring example of racism in a Canadian health system happened in Queens. So in 1918, the Queen's University Senate voted to ban Black students from enrolling in its medical school with immediate effect. It was only in 1965 that Black medical students first enrolled at Queen's Medical School, and it took them so many years. And 5 years ago, the Senate have actually apologized for that. And this does speak about the underrepresentation of African Canadian Black students in medical schools across. And now moving on to chat about discrimination in the learning environment.
Thank you, Nayef, so much for these very important examples, and they will help us contextualize the next section, which is discrimination in the learning environment as experienced by learners. So before going over some specific examples, I wanted to introduce this framework, which is a bit similar to the one that Nayef introduced earlier, but looking at the 4 eyes of oppression. You may have heard of this framework before, and it applies to our healthcare system and to any system. So looking at these are the different levels where you can find oppression or perpetrate oppression. Ideological, so the belief that a certain group, the majority, is superior to the minorities. And that makes sense when we think of our colonial past and what our systems are embedded in. And then this will then influence our institutions. And on an institutional level, when we look at healthcare, it can be through the leadership, through the policies, through the services. Racism can continue to be perpetrated. And then that will lead to individuals having their own internal biases, and that will influence their interpersonal interactions. So that can be with patients, that can be with colleagues, that can be with learners, with allied healthcare professionals. So there are various places where oppression can be perpetrated. And finally, this all leads to internalized racism. When we look at internalized racism, there's two sides to look at. So first, the side of those that are facing the oppression, the minorities, they will internalize the feeling of being inferior and added stress and pressure to prove that they are equal worth, so equal level of professionalism, equal level of competency. They will have to put more efforts to be considered as equally worthy as their white counterpart. And then when we look at the other side, the flip side, the white majority, they will internalize a feeling of entitlement and a feeling of being superior to those to the minorities. And all of that will interact to eventually influence the learner's experience in the healthcare system as they navigate their medical education journey. This is a narrative review that was done in the United States. It was published in 2021, where they looked at the role of implicit biases and their impacts on the medical learners in the educational settings. And what they found were these different sources of racial biases. So peer-to-peer from healthcare educators and assessors, the hospital and clinic environment, and also the learning environment. And what they discuss in the specific articles is that there's been multiple studies that have shown that there are racial and ethnic disparities in academic performance. So be it clerkship grades and overall academic outcomes are decreased for minority students, despite them having to meet the exact same requirements to enter medical school. And some other findings of this review is that students experience prejudice based on their racial identity and struggle with stereotype threat, which is the internalized racism we were discussing. A quote from that specific study, one student said, from a minority group said, "We have to be exceptional to be considered average." So again, it's this added pressure to have to perform more, to put more effort to be considered the same levels as others. Then another finding was that racial and ethnic minority students receive more negative comments and less positive comments than white students. And then there are unconscious patterns of bias that are propagated by healthcare professionals in more senior roles. In that narrative review, they quote a specific study that was done in the US as well. They surveyed 3,500 students that are non-African Americans to any other communities, and they asked them if they ever heard a negative comment about a Black patient, and 48% of them, so nearly half of them reported having heard a negative comment about a Black patient, either from a resident or a senior staff. So this goes to show how the continuous presence of our own biases and then the presence of racism in the healthcare system continues to impact Black medical students and medical students from different communities as well. And what they found in that specific study as well is that there was a statistically significant increase in the internal bias, those students that were exposed to negative comments. So again, senior staff and healthcare providers in senior role can continue to perpetrate racism through their own biases and also through the educational system. Then this is another study that was published in 2022 in the US as well, has similar findings. It was a survey among different medical students. And I wanted to just share this diagram that I think nicely puts an image, illustrates the different factors, how they interact together to eventually lead to racial and ethnic disparities in clerkship grades. So what we see is here the social media of medical education, where people come in with their own societal influence and characteristics and are then immersed in the social milieu of medical education, where biases can be present in assessment processes, in student interactions and reactions, and in the learning environment. And all of those factors will interact to eventually impact their academic performance. Now that we know that, we'll be looking at a few case examples. So the first one is the one of anti-Black racism. So this is an article that was published in 2024, was done at the University of Saskatchewan Faculty of Medicine, and they interviewed 9 medical students and 4 residents from the Black community. And what they found in that study is that all of them experienced racial discrimination in the form of uncomfortable conversation, microaggressions, or blatant acts of racism. One specific quote that I found quite striking in that specific study is a student shared that while being in a clinical environment, one of their supervisors used the N-word. And this is a study from 2024. This is not from 60, 80 years ago. So this is still very much, very, very current and still being happening in the healthcare system. And again, impacting the well-being of our learners. And a diagram that they shared in that specific study is the exposures to racist experiences or the potential source of racist experiences as you move through your medical education journey. So as you progress, you're exposed to more and more sources of potential bias. And as you become a resident, you're both an employee and a learner. So you're exposed to both racism from the curriculum, peers, but also from hospital leadership, allied healthcare professionals, attending physician, consulting physician. So more and more sources of potential bias. Another study that has similar findings in terms of experience of Black medical students here in Canada. This is a study that was done through the Black Medical Student Association of Canada. It went published in 2022. It was sent out to 128 medical students that could have been potential participants. 52 of them responded. And out of those 52 respondents, 59% had at least one experience of discrimination, including from patients, peers, and staff. And what they also looked like in that specific study was the different dimensions of their experience in medical schools. So they asked the participants if each of these dimensions was mostly associated with positive versus negative experience. And what we see is reassuringly, academic inclusion, clinical inclusion, and resilience are associated with more positive experience. But what is more worrisome is that when it comes to discrimination, well-being, career advancement, minority tax, and this diversity in medical education, it's mostly associated with negative experiences. And there was a similar study done in 2020 among medical physicians here in Ontario, and 70% of them had reported facing discrimination in the healthcare environment. So again, this is still a very current and ongoing issue. These are very recent studies and goes to show the extent of racism in our healthcare system and how much work we still have to do. Now, our second case study is the one of anti-Indigenous racism. So this one is a study that was published in 2017 and was done at the University of Manitoba Faculty of Medicine. And they surveyed 9 out of 45 potential participants through interviews. And what they found in those interviews is there were common experiences when it comes to experiencing otherness, having different challenges in studying medicine, the learning opportunities that were available to them, and the importance of strengthening resilience and navigating medical school. But one concerning universal experience highlighted is that they all faced racism at various levels. And what racism was, what were the forms of racism? Microaggression. So that can look like their peers assuming that they do not meet the same entry requirements because they're Indigenous, or that it is easier for them to get into med school because of a separate pathway. Institutional racism and difficulties challenging that racism. Out of the 9 participants, only 2 ended up challenging the racism that they faced and felt that they had a safe way to do so. There is personally mediated racism and internalized racism. There is also a story from that specific study. A student shared that they were in the operating room at some point with a resident and a staff. And during a casual conversation, the resident said something along the lines of, the best thing that could happen to Canada would be if Indigenous people stopped reproducing. Again, I just want to pause and also reflect on the different examples, the historical examples that Nayef had shared earlier, and seeing how much harm has already been done to Indigenous communities. And that continues to be perpetrated through our own personal biases, but also different levels of oppressions that are very rooted in our health system. Again, a lot to do to address, which I will let Liyana go over a bit later. But before that, I want to go through a last case example, which is the discrimination experienced by international medical graduates. So this is a very important topic and relevant given we have a lot of international medical graduates, and we'll be going over some statistics a bit later. But this is a study that was published in 2023 in the US, and they looked at the medical inferiority bias experienced by international medical graduates. And what they discussed in that specific study is that there's multiple studies that show that IMGs, international medical graduates, do not perform any differently than American medical graduates or Canadian medical graduates in our case when it comes to patient outcome, but that they're still being perceived as inferior by the medical community. And this is a quote from that specific study that says, numerous personal stories of foreign IMGs voice more hostile and overt encounters from colleagues, patients, and staff, and the data suggests higher severity of disciplinary action for similar transgressions. And before we go any further, I want to define a few things for when it comes to IMGs. So here they say foreign IMGs. So what they mean is immigrant IMGs. So when we talk about IMGs, there are three types. You have the Canadian IMGs, those that are from Canada, go abroad to study med school and come back to complete residency here. Then you have foreign IMGs that are those that are born and raised in another country, do medical school abroad, and come in here as immigrants for residency. And then you have the visa trainees, where there is a bilateral agreement between two countries, and a specific country will fund their medical student and to come and do residency here and eventually go back and practice in the country. This will be important for the next study we'll be looking at. This is a study in the UK, and just to draw some parallels, the UK, the US, and Canada are similar in the sense that IMGs make up a big proportion of our physician workforce. And what they found in that specific study in 2023 is that 58% of IMGs had faced everyday instances of racism at work, and only 72% of them did not report the incident because they didn't think they would be taken seriously. And now looking specifically at our Canadian context, IMGs make up about 27% of the Canadian physician workforce, and we have similar statistics here in Ontario. And something to be known is there are very limited spots in residency for IMGs, that it's much more competitive for them to get a spot in a Canadian residency program as compared to Canadian medical graduates. So as an example, in 2020, out of 2,085 IMG applicants, only 418 were able to get a spot in a Canadian residency program. Now, with that context, there is a study that was actually done, co-authored by some physicians here at CHEO and some physicians at the Montreal Children's Hospital. Dr. Walid Al-Qurashi, who's one of our current emergency physicians, is the main author on this one. And this is a study that was done from 2009 to 2010, and the objectives were to look at curricular needs experienced by different groups of IMGs, and then to explore the impact of education and social cultural issues on IMGs' training experiences. In this study, they sent out the survey to 340 people, and 137 of the IMGs from across Canada answered, which is about a 40% response rate. And then what they found is that 1/3 of all types of IMGs experience discrimination from staff. 52% of visa trainees experience discrimination from nurses, and we'll look at the specific numbers and show that visa trainees are also are also facing higher rates of discrimination from certain groups. And then 1/3 of all types of IMGs had difficulties adjusting socially to their program. Now looking at specific numbers, so again, from the faculty, it's about 1/3 in all categories, but then when you look at nurses and patients, the proportion gets higher as you move from Canadian IMGs, immigrant IMGs, and then significantly higher in the visa trainee group. And then looking at learning and education issues, overall positive results. So when it comes to receiving a fair end of rotation evaluation and feeling that they were treated the same as other Canadian residents, most residents said that they had positive experiences. However, when we look at the visa training group, we can see that that proportion is much lower than the other groups of the Canadian IMGs and the immigrant IMGs, where 1/3 of them did not feel that they had a fair end of rotation evaluation, and 1/3 of them didn't feel that they were treated the same as Canadian residents. Despite this being a study from 15 years ago, this is still a very relevant issue. We still have more and more IMGs as part of we still have IMGs in all of the residence cohort and more every year. And speaking to them, you will hear similar stories still happening and still facing discrimination here in our working environment. And we do have a responsibility to address that and work on providing a better experience, a better learning experience for everyone. And I will now let Liyana go over some ways of doing that.
Thank you so much, Iman, for those really important and impactful examples. Apologies for being unable to join you all in person today. I'm out of the province on elective. My section is going to be talking about addressing discrimination, so specifically talking about tools and opportunities for bystanders to intervene when microaggressions are witnessed. So this is just kind of an outline of all the different people that may or may not be involved in situations where microaggressions can occur. Usually there is a perpetrator, a subject, and there may or may not be a bystander.
Give me 2 seconds, Liyana. Sounds like we're not hearing you super well in the room. Is there a way to
Oh,
go up
okay.
volume? At max volume on the computer?
Okay, what about now?
I think it's more of a issue of proximity here. I don't know if I can move
Oh,
this.
okay, okay. Just let me know.
Yeah, if you can try to speak a little bit louder.
Okay, how's this?
Sorry. Thanks.
Is that a little bit better?
Yes. Yeah.
Okay, okay, I'll try my best. Okay, we can move on to the next slide. This is an infographic kind of just detailing the different levels at which microaggressions can be addressed. Each of these levels play an important role in addressing microaggressions and promoting racial equity in healthcare. So from a personal level, what you can do is set boundaries, engage in self-care, and assertively address microaggressions as they occur. From an interpersonal level, you can foster open dialogue, you can educate your peers, and model inclusive behaviors. From an institutional level, you can advocate for EDI training, be aware of reporting mechanisms, and inclusive policies within healthcare organizations or academic settings as a whole. And from a societal level, you can support public awareness, push for systemic reform, and advocate for racial equity in healthcare and beyond. So a lot of the literature available on microaggression intervention actually focuses on helping the target respond. And this sends a message that the target is solely responsible for addressing harmful behavior. The burden to educate the perpetrator and highlight the microaggression should not be on the person experiencing the microaggression. There have been studies investigating racial microaggressions experienced by graduate students of color that have found it to be a significant predictor of burnout. So these are some of the frameworks that are available that are kind of outlining how to respond as a person experiencing the microaggression. To the frameworks reviewed above, both Open the Front Door and XYZ, direct the recipient on how to respond to the microaggression, but don't actually prompt the recipient to ask for clarifications on the comments or the actions. So just to define what a microaggression actually is, it's a statement, action, or incident regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as a racial or ethnic minority. Years of empirical research on microaggression theory have established that it results in adverse mental and physical health and creates toxic work environments within education, healthcare, and just broadly workplaces in general. So I invite everybody to reflect on this. You don't necessarily need to comment on what the microaggression was if you don't feel comfortable, but if you do, please feel free. Have you ever recognized a microaggression? If anyone has any inputs, just let me know. Keeping an eye on the chat as well. But we can move on in the meantime. There are different types of microaggressions. So there's micro assaults, micro insults, and micro invalidations. And I'll just go through a couple of examples for each one. So for example, if there was a senior staff referring to a Black medical student as the token Black person in the department, that implies their presence is only because of their race and not because of their qualifications. This would be an example of a micro assault, which is an overt and intentional act of discrimination. For the next example, if a resident is saying to an Asian medical student, you must be good at math, right? That's why you chose radiology. This comment assumes that all Asian individuals excel in math, perpetuating a stereotype about their intellectual abilities. And this is an example of a micro insult, which is an unintentional communication or behavior that conveys insensitivity or rudeness. And then our third example is where a medical educator brushes off an Indigenous medical student's comments about cultural barriers in healthcare by saying, that's just your opinion. I don't think patients in this area have those problems anymore. And what this does is this invalidates the student's perspective on the ongoing impacts of colonialism and healthcare inequality. And this is an example of a micro-invalidation defined as unintentional communication or behavior that minimizes or negates feelings and experiences that are a reality for a marginalized group. So when we talk about goals of intervening, this is targeted towards intervention by a bystander, specifically towards learners. So the goals of intervening would be to safeguard the learner and protect and promote a safe learning environment. And when effectively done so, it actually achieves three things: provides support and reassurance to the target or the subject of the microaggression, recognizes their value as a person, and validates their experience. Allyship in the context of anti-oppression has been defined as a lifelong process of building relationships based on trust, consistency, and accountability with marginalized individuals or groups of people. And similarly, the goal of critical allyship in particular refers to working in solidarity with people who are disadvantaged by structures and systems of society that uphold the said inequities. So moving forward, there's actually three major steps that need to be taken. So the first one is to acknowledge implicit bias and microaggressions. The second one would be to counteract both unconscious and conscious bias. And I'll talk a little bit about different frameworks to respond to microaggressions in a little bit. And then the third, more long-term goal would be to diversify the workforce and promote a healthy working environment by having multiple perspectives present. So there is a powerful kind of concept from a book that was written in 1970 called Pedagogy of the Oppressed. And it's this concept that we disempower the innuendo by naming it. The author, Paulo Freire, concluded that the first step to liberation and empowerment is actually naming the oppressive event, condition, or like process so that it no longer holds power over those that are marginalized. Social psychology research on bystander effect actually indicates that other people's presence reduces the likelihood that an individual will help, especially when situations are deemed to be non-urgent. So in the face of microaggressions, we would like to empower you to transition from being a bystander who just stands on the sidelines to becoming an upstander who takes action in the spirit of true allyship. And this can be done using either indirect or direct strategies. So there isn't really any consensus on whether indirect or direct strategies are more effective. I think there are nuances. Indirect strategies are generally more effective when dealing with situations involving power imbalances or in situations where confrontation could either escalate tensions or if the microaggression is really subtle and doesn't necessarily require immediate confrontation depending on how you've perceived it. Direct strategies are often more effective when you feel confident and safe and supported, or situations in which immediate clarity or education are important. But in most cases, a combination of both strategies might be the most effective. So, for example, using indirect methods to address the microaggression in real time, and then follow up with direct conversation after the fact to explain the impact of their behavior. So just to go through a couple of examples, Iman, if you don't mind just going back. Couple of examples for each type of intervention. So redirecting is pretty straightforward. You change the subject or shift attention away from the target. Uplifting is the concept of elevating the target very broadly by countering the microaggression with affirmation. For example, if you encounter a medical student where a patient has made a derogatory remark, you can just generally uplift them by saying in front of the patient, you are partnered with an amazing provider and are so fortunate to have them take care of you. This doesn't directly address the microaggression, but it just generally uplifts the target. Whereas besting creates a space and invites the target of the microaggression to actually prove their knowledge or their skills in the area. And it's a more specific way of elevating them. And in terms of direct intervention, you can reflect back what the perpetrator has said. So for example, I heard you say XYZ. Can you explain what you meant by that? You can directly communicate the impact of the words to the perpetrator as well. So using words like XYZ has made me uncomfortable. You can also raise awareness by using phrases like, I believe a more inclusive term is XYZ, to also educate the perpetrator on the terminology that they're using. After the fact, if you choose to re-engage with the person, you can always check in. So you can reflect on the conversation and reach out after and just ask if you have time to check in. And this can be a way of directly addressing the microaggression, not in real time. And then reaffirming boundaries is just to emphasize that respectful language is expected and disrespectful language is not tolerated. So we'll just go through a couple of examples. I'll describe some cases, and I invite you to reflect on the way that you would approach the scenario as a bystander trying to intervene using any of the strategies that I was talking about a little bit earlier. So I'd like you to imagine two medical students, Alex and Jordan, these are random names, who are discussing their recent patient interactions. Alex, who is a person of color, shares an experience where a patient was particularly warm and friendly towards them, and Jordan, who is not a person of color, responds with something like, "Wow, I didn't think patients would be so receptive to you." So the underlying meta-communication is that patients might have an inherent bias against people who look like Alex, even though that's not what Jordan has explicitly said. How can we counteract this? If anyone would like to put some thoughts in the chat, or even just self-reflection is really, really important. If you think about the tools I was speaking about earlier, how would you approach the situation as a bystander? And we can just move on to the next example while you think about that. Unless anyone has
Yeah,
any.
I know you can't hear them, but there's someone who's going to be saying something
Oh,
in the
okay. Okay, great.
and I'll read it afterwards.
Great.
You say that. As I think her meaning is, as opposed to the assumption the patient should be uncomfortable with it.
Mhm. I'm just going to repeat what was said for everyone in the Zoom. So we had a participant say that they would ask the medical student if their assumption would be that the patient would be racist or should have would have a racist bias towards them. Is that kind of what I'm understanding? Yeah.
But this,
So yeah, asking the white medical student if they assume the patient is racist or they assume that these patients should be thinking less of the patient, the colleagues of a minority, the colleagues of color. So this is a thought that was shared in the audience here.
Great. So yeah, naming the microaggression and putting a label on it, which is incredibly powerful. Okay, if anyone else has any thoughts, let me know, but otherwise we'll just move on to the next example. So in this case, we'll be talking about Sarah, an Indigenous medical student who's discussing her career goals with a staff during a clinical rotation. And the staff just says in a half joking manner, "Are you planning to go back to your community and work there? I bet they really need you." And this comment, although it could sound supportive on the surface, it actually makes assumptions about Sarah's career aspirations and reinforces these stereotypes that Indigenous students are or should be obligated to work in underserved Indigenous communities, places an undue expectation on her based on her background, rather than her own goals or her professional interests. When Sarah obviously expresses a little bit of discomfort or surprise, the staff responds by saying, "I was just joking. We know we need more people like you out here." These types of microaggressions not only place additional pressures on Indigenous students to fulfill roles based on these stereotypes, but it actually also dismisses their individual agency and choices, suggesting that their purpose or contribution is predetermined by their identity. And this can leave students feeling isolated or stereotyped in a way that their non-Indigenous peers might not experience. And then we can move on to the third example. So I'll have you imagine Dr. Patel, a resident doctor of South Asian descent, working with the staff. And during rounds, the staff compliments Dr. Patel's medical knowledge by saying, "You're really good at this. I guess you people have a knack for science and medicine." And so this comment, while framed as a compliment, is a microaggression because it actually reduces Dr. Patel's accomplishments to a stereotype, assuming that their medical abilities are due to a cultural or racial background, rather than individual talent, hard work, or dedication. So again, I invite you to think about how you would counteract this if you encounter this situation as a bystander. So just to kind of wrap things up, there was a series of workshops that was done in Canada between 2020 and 2021, focused on empowering occupational therapists with addressing microaggressions. And basically, they were given some tools, they were given some examples, and they felt empowered to kind of work through those examples, and they were given a post-workshop survey. And what the post-workshop survey showed is 4 main themes. Basically, when these participants were asked to employ strategies to address microaggressions, they realized that, as Nayef kind of emphasized earlier as well, we have so much to unlearn. It's so important to remain humble. We need to acknowledge positions of power and recognize that you are not an expert in the lived experience of others, and there's always room for personal and professional growth. This third point really spoke to me. Resist the silence. It's so important to use your voice and, again, name the microaggression. And that discomfort is okay. And that's what brings about change. So for the person experiencing the microaggression, if you have ever experienced a microaggression, or if you do in the future, you can always reach out to your program director, the deputy chief of staff, the professionalism office, or the EDI office. And the literature has proven that developing resilience through self-care, spirituality, mentorship, or collective organization will actually help just in generally like developing resilience. But again, I want to emphasize that the onus should not be on the person experiencing the microaggression to address it. But these are some additional ways to develop resilience. More importantly, for the ally, do your homework, recognize your own biases and prejudices, learn to recognize the different types of microaggressions and call them out. Be open to feedback. We're all on a learning journey, and be cognizant of the language that you use. Just a disclaimer, as we were talking about learners in particular, there are always some situational considerations. So please consider the environment when addressing concerns. Harsh but sad reality is that sometimes you have to pick your battles, and then always be cognizant of possible consequences and relationship dynamics. Although in an ideal world, this would never stop you from speaking up. So just to conclude, our take-home points are that racism in medicine has influenced and continues to shape healthcare disparities. Racial discrimination is present in various layers of the healthcare system, including the learning environment. In Canada, Black, Indigenous, IMGs, and other racialized learners face racial discrimination in their medical education journey. Microaggressions can present in many different ways. It is important to educate yourself on recognizing and acknowledging them. And there are steps that you can personally take to dismantle racism. Resist the silence. Thank you all so much for attending our talk. If anyone has any questions, let us know.
Stop just sharing the that we can. Oh, wow, there's a lot of people online. Okay. We didn't see them earlier. Okay, that's great. Okay, good. Okay.
Watching you guys walk over the court each time, I'm getting a little nervous. So thank you very much. I wanted to open the floor to questions, but I actually wanted to ask a question myself first, and it was about the definition of the term Black in 2024. And the reason I asked the question is I was once nominated for an award for Black physicians by a family member of a Black family for work I'd done around sickle cell disease and newborn screening in Canada. And my immediate question was, am I Black? I'm not sure how that's defined. I don't perceive myself as that, but I don't know if that matters. I didn't want to decline a nomination from a family, nor did I want to misstep in, that area of identity, self-perception, societal assigning of race, all the things you were talking about in the introduction. So I found myself wondering, is there a 2024 definition of that term? And you could say, I don't know, but I wasn't sure. Yeah.
I don't personally know. I don't know if Nayef, if you have any input based on your section, or Liyana, or if anyone in the chat has a specific definition that they know. I don't personally have one. I see a hand raised in the chat, but I don't know if it's for that to answer that specific question,
No,
or it was already raised before. Okay, but anyone has a specific definition or know of one, and they wish, Dr. Simpson is here. Perfect.
Hi, so thanks for the question. I'll take a stab at the question. So I think it brings up a very important point in talking about the fluidity of race and how it can be self-assigned or externally assigned, because perception based on your phenotype can lead to somebody to classify you as any given race. But the definition that I know of relates mostly to individuals of Afro-Caribbean descent with respect to ethnicity. But with that being said, there have been individuals who have self-classified as being Black or not Black in spite of having that ancestry or not. So I think it just, again, raises the important point of race being a social construct and not really something that is very clearly defined. And so I don't know what happened with that nomination. I think you should get awards for your work related to sickle cell disease, but of course that's my bias. But it's something that probably could be debated in many different ways.
Yeah, thanks, Ravina. Yeah, and as you were speaking, I was reflecting again on the recent American presidential election and the, conversation, and maybe that's the wrong word, I don't know, about Kamala Harris's, racial identity. Anyway, it goes, I think, just to underline the social construct nature of race, and someone with genetics background and work, there's also genetics that plays into population ethnic differences. So it's a complex area. So anyway, Fahad, you've had your hand up patiently. You want to go ahead?
Hey guys, thanks. Can you hear me, by the way?
Yeah.
Yeah, okay. So I just want to thank the three of you for doing this talk. I know not too long ago I was also in your position, and I gave a very similar talk on racism in medicine as a fellow here at CHEO. So I know it's hard to do. It's a heavy topic, but also I know, the three of you and many people carry sort of the weight of racism. So I have a question, and again, just like Pransh said, if you don't know the answer, it's fine, because I definitely don't. So, there's no doubt that these structural and institutional racisms exist within medicine and our hospitals. And, to combat this, so many institutions have put in place EDI strategies and EDI task forces. But the paradox of EDI working groups and strategies, though, is that they actually function within these colonial structures, and they're created by and also for institutions that have a long-standing history of, disenfranchising minorities already. And you can see that when EDI committees suggest changes or ideas that aren't necessarily in line with existing racist policies. So it's sort of like resisting the silence. So what strategies have you maybe seen or come across, and how do we move that target forward when we do anti-racist work that can be viewed by the institution as not important or too political, or even worse, unprofessional within those institutions?
So who wants to take that one?
Anna, it relates a bit to your section. I can give it a try as well.
Honestly, it is a good, very, very thought-provoking question. I personally don't have an answer, so Iman, if you want to weigh in, Dr. Simpson as well. If
I
anyone
can
has
weigh in.
thoughts, go
I can
for
try
it.
weighing in a little bit, and I know Fahad, you have much more experience than I do when it comes to navigating and those leadership positions. But I think we just have to acknowledge and realize we are in a system that is embedded in a colonial past. And, you know, we can't dismantle it from one day to another. There is going to be a lot of work, and I think we have to do our best to do what we can within those existing institutions, and also recognizing that the colonial influence is still there. But that also we have a responsibility to name it and be explicit about it, even though it can be considered unprofessional or shocking. But I do think we have to do our best to work towards that target that you were mentioning with the institutions and the committees that are already existing. And it's our responsibility as well, now that we know, to take on those roles and try to push forward in that direction. But I can let anyone else who has more experience weigh in on that as well. I know it's not an easy thing to tackle. We would have an answer. If it was an easy answer, we would have solved it already.
Okay. I'm happy to chime in, but I think what you've said is very thoughtful, and you know, it's a very difficult question to answer. I completely agree. And having been in an EDI role recently, I can speak to the fact that, you know, when there's change to be made, it'll be very slow, and you do have to work within the institutions that you're in. But with that being said, I think that as frustrating as it may be that we have to have EDI as a siloed entity or topic to challenge, I think that really for it to be truly embedded in culture, it has to start at the leadership level, where, you know, we really need to push for our leaders to have the education to also name these microaggressions, these racism related issues, but then also engaging those who are most effective to also be able to contribute to the changes or recommendations without putting all of the burden on those individuals. But I agree that, you know, there is no simple answer. And I don't think that's what you were trying to suggest, Fahad. I think it's very complex, and clearly we have a lot of work to do.
Thank you.
Thanks. We have a couple of questions. I will share, I did in part apply for this job with this conversation in mind. I think diversity is something there's a lot of evidence that diversity in all its forms makes institutions, conversations, groups more resilient and stronger. And on reflection, I was realizing I don't remember if Canada's ever had a visible minority chair of pediatrics. So in part in conversation with my kids, we were talking about that with colleagues and friends. And, I wasn't 100% sure I was going to apply for this job. In the end, I did for a number of reasons, but this was actually a big one. I think it goes to part of your question, Fahad, and part of what you were saying, Evie, as well, in terms of, influencing the structures by influencing diversity within the structures. So, encouraging people to move away from that internalization to be willing to take that risk and that step. Certainly something I spend a lot of time thinking about. So anyway, thought I'd share that. Don't think I talked about that openly in the past. Dr. Batra.
Well, very, very complex topic here and nicely presented. I would like to mention about gender discrimination. I work in mother-baby units. And when I go to see the mothers in there, most of the time or sometimes, they reject me seeing them. So I used to feel bad about it, that you see, I'm also a doctor there, but they prefer a female doctor, right? That's fine. Now I have changed my attitude. I've changed my attitude. When I come out, okay, well, very good. One less patient to see. I'll send it to someone else, all right? However, you see, I think it's an attitudinal thing as well. I think some of the things may be said by some colleagues or seniors. I think we don't have to really think too much about them. I think we have to use a little bit of your thinking as well why this particular thing was said. Now, my question to you is this. You guys have been here for a very long period of time at CHEO. How do you find yourself? Is there any change in the situation when you came in as opposed to the present time?
And I think that's a question to the residents, I guess. Over the 3-year period, have you seen or felt any change, or did you have time maybe to reflect and realize that there was a need to talk about? I think there's various ways to field the question. Liyana, do you I want to make sure we give an opportunity for you to answer as well?
Sure, thank you. I think for me personally, being a Canadian who trained abroad, so like a CSA, there have been multiple instances of subtle microaggressions I've experienced in that regard, and I won't say there's been too much change on that front, but again, it's been pretty subtle and not that frequent. But I personally haven't noticed a huge shift.
Thanks. And I think we have one last question. Christian Scott, who's in the room, and instead of repeating the question, I just asked him to come up and say it.
Thanks. I want to congratulate John. A great talk. It's always very difficult. What I particularly enjoyed was a lot of ways that people can contribute. The ally contribution thing was very powerful. One thing I see a lot of that I wonder about is a manifestation of microaggression is the use of the mispronunciation of names, or the mispronunciation of names, and I wanted to get your perspective on how that, how what's the best way for that to play out? Because there's this habit some people have of deliberately mispronouncing a name or not doing the work to try and get it right. But then in trying to do the work, sometimes you make a big scene, and then it also can maybe be an uncomfortable space where you're going on for 5 minutes about trying to get the name right and then give up and pronounce it unpronounceable, which I guess is a very serious form of microaggression. So can you talk about names and the work of getting the name or the pronunciation of the name right?
Thank you, Dr. Scott, for this question. It's a very valid question. Sometimes we even hear people referring to physicians by their first name because they can't pronounce their last name. So it's easier for them to say doctor first name rather than doctor last name. And I think, one of the easy way to tackle this issue is basically to ask, or at least try first and then ask them if this is how it's pronounced. And I think it's a big issue when people are not trying, they just prefer to use the first name instead of the last name because the last name seems to be difficult. And even if you mispronounce it the first time and someone corrects you, it's completely fine to nail it the second time or the third time. And I think it's also we live in a multicultural society. So many patients, we can't we don't know what's the correct way of pronouncing their name. And I think the best way is, what do you want? What do you want me to address you as? And I think I agree with you. I think this is one of the things that we don't have a lot of experience in. And actually, I would highlight a point, a study that was published, I think 2 years ago from the University of Toronto. Was done it was done over a period focusing on the pediatric residents and about their comfort with EDI. And actually, Zachary Blattman was one of the co-residents. He was the co-author of that study. And people felt that EDI is a soft skill. So you don't need kind of to have it. You don't need it to pass, your exams in medical school and also your exams during residency. But I think one of the things that they've suggested is to include it as part of examining medical students. Everyone knows how to do a good abdominal exam, but no one is comfortable with talking about EDI. So I hope that this answers part of the question. I'm not sure if Liyana has any comments.
I agree with what Nayef said. I think it's just important to try, and that itself carries so much weight in terms of seeing effort.
Yeah, thanks. And I think we'll wrap up. We're coming up to the end of time. Oh, we're actually, that clock in the back is 5 minutes slow. Yeah, so thanks everyone. I'll just share in response to Christian's questions. Often people will ask me, what do your parents call you? Or how do your parents say, or they actually say, how do they call you? And they actually call me Papi. So I just say they call me Papi, right? And then I think you're trying to ask how to say my name. So I think humor for me is also, especially when someone with very good intentions is trying to ask that question. So anyway, thank you. Thank you very much to our presenters online and in person, and for all the good questions and discussion. So see you next week.